And I'm delighted to be able to host this morning and present our guest speaker. Before I get to that, I do want to start with our land acknowledgement. Ottawa is built on the unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. Our guest speaker this morning is Dr. Susan Moffatt-Bruce, who's a professor of surgery at the University of Ottawa and the Chief Executive Officer of the Royal College of Physicians and Surgeons of Canada. Dr. Moffatt-Bruce joined the Royal College as CEO in January of 2020. In 2021, she additionally became the Chief Executive Officer of Royal College International. During her tenure thus far at the Royal College, she has overseen the transformation of assessment methodology and an in-depth enablement of informatics and data governance for the college, residents, and fellows. Susan is an academic administrator and surgeon with a sharp business acumen and a passion for value-driven care. She holds degrees from McGill University, Dalhousie University, the University of Cambridge, and the Ohio State University. She is a well-funded research scientist and a practicing thoracic surgeon. She has held leadership positions in numerous national and international associations. Previously, prior to coming back to Canada, Dr. Moffatt-Bruce worked as a chief quality and patient safety officer and senior hospital executive in Ohio. She is, as mentioned, she's a professor of surgery, both at the University of Ottawa and the Ohio State University. Dr. Moffatt-Bruce is speaking to us today as the final speaker in our PSI Foundation funded series on learning health systems, and so a very appropriate speaker for this topic. We're very grateful for PSI in supporting this series of speakers and workshops that we've had over the past couple of years through their mission statement of improving health for all Ontarians through through physician engagement and empowerment to perform research, education, and knowledge translation. I want to reach out and extend a huge thank you to Jim King, who has supported the PSI Foundation and this lecture series, and to Heather Howley from the Research Institute, who has been instrumental in coordinating this series and bringing speakers to CHEO. The title of Dr. Moffatt-Bruce's presentation is Leveraging the Learning Healthcare System to Sustain the Gains. Welcome, Susan, to CHEO and the Department of Pediatrics.
Great. Thank you so much, Jason. And thank you, everybody who's here this morning. I'm going to go ahead and share my screen. And I have about, maybe 20, 25 minutes worth of a presentation, and then I'll just open it up to conversation, because hopefully what I present is something that can start and maybe continue a conversation that you've already had around enabling learning healthcare systems. So with that, I'm going to go ahead and share. And all right, and if I could just get a thumbs up on that, that is working.
Do you mind going into your presentation view?
Sure.
So we can.
So I'm in presentation mode now.
Mm-hmm.
How's that working?
I still see all your slides. If you just go over to slideshow, that will help. 1, 2, 3, 4, 5 over to your right.
To my right, okay.
Mm-hmm. It says file, home, insert. No. See if I
Susan, I think at the bottom you are on all slides presenting at the bottom of PowerPoint presentation. Maybe from there you can go.
Mm-hmm.
Interesting, because I just did this a few minutes ago, didn't I?
And it worked.
I know.
Well, if it's easier, you can get out of that and start over. Do you have two screens?
No, I just have the one.
Okay. Click
Why
on
don't I just,
click on your first slide.
yes,
That'll,
no? Okay, what I'm going to do is just stop sharing and then go back in, okay?
we'll try that. I apologize. I had trouble sharing myself today.
Okay.
Okay, there we go.
Now hit the lectern, yeah.
Yeah,
Any better?
there we go. Perfect. Thank you. Thank you.
All right, well, everything else should be easy then today. All right, well, great. Thank you very much. And again, Jason, thank you for the kind introduction, and thank you to everybody for joining me today. I'm Susan, and I'm so pleased to be talking to you about something that really resonates with me. And I've spent a good part of my career trying to understand and study, which I refer to as the learning healthcare system. So today I do have my objectives were sent in advance. And I'd like to talk a little bit more in depth about the concepts and the principles behind a learning healthcare system. Also, just to talk about how engaging team members in the learning healthcare system, and then how to perhaps even sustain the gains as well as the pieces of the learning healthcare system going forward. But maybe first and foremost, just taking a moment to just give you context. This is, I think over the last couple of years, we've all had this ability to kind of reframe and relook at things that we've done well and things that we want to do going forward. I am very committed to this concept of the learning healthcare system, because I think we all work within systems that have very strong pieces of this puzzle that enable learning healthcare systems that ultimately improve patient outcomes. And I think we all may play a different part in it, but I think that we all have that ability to be part of the team ultimately. I do think that what we're talking about, the learning healthcare system, it's not always easy. There are so many competing priorities. We just had a conversation with the surgeons, and honestly, every day it seems like there's things that are on fire. And sometimes you feel like you're like in this picture, the only light ahead is so small that it's hard to realize that maybe we'll make progress. But all that to say is that I do think that collectively we can move forward the concept, the pieces, the infrastructure that enables learning healthcare systems, and ultimately the patients and all those that we serve will benefit. On just personal note, and this is my favorite picture from Prince Edward Island, where I'm from, to give grand rounds today at CHEO is truly a delight, and to be part of this group today. My mom worked at CHEO for many, many years in neonatal intensive care and pediatric cardiology, and I know she would be very proud of me today to have come full circle. So thank you for this opportunity. So I think it's fair to say that we've realized, and we continue to realize, that truly is not the strongest that will survive, nor the most intelligent, but those that are most responsive to change. And I think within healthcare, maybe many other environments as well, but I think in healthcare in particular, and we've seen that we can change. If you think all that has gone on just in the last 2 years, let alone the last decade, we have the EMRs, we have virtual care now that is really embedded in our systems. We connect virtually for our rounds. We love to be back in person, but we've changed to meet the challenges. And I think a lot of this responsivity is what is inherent to a learning healthcare system, because we're learning all the time how to be responsive and how to get the work done to engage and improve the life of our patients. And so I would argue from the very beginning of this conversation that we already are part of a learning healthcare system, and we have this ability to continuously expand and advance on it. So there are many definitions of learning healthcare systems, and I do think that the pieces of the learning healthcare system are inherent to the systems we're already in. And I think the first one, really having leaders that are committed to continuously learning. Now that might be bite-sized, that might be large projects, but having leaders that are really engaged at the front of this queue of perpetual learning is completely required for a learning healthcare system. Being able to be systematic in the approach and really trying to guide care and changing the way that we take care of patients today, completely different than how we took care of patients 5 years ago. And speaking to that and documenting that and celebrating in the changes that we've made. There is a component of a learning healthcare system that is dependent on infrastructure and IT enablement. And that can be part of the EMR, but I think there's other pieces to it as well. And there are other data sets, there's other data elements, there's other decision-making tools that can be used, and all of those pieces that make it easy to do the right thing and improve outcomes can be really leveraged as part of the learning healthcare system, including patients in the care. This is probably a phenomena that, you know, in the pediatric world, I know that you have a deep understanding and engagement with patients and their families. And I think this is something that we are continuously trying to elevate: patient-reported outcomes, patient advocacy, engaging patients in all of our committees. This is something that is just so fundamental to the learning healthcare system because we learn so much from our patients and our families. And then lastly, always capturing what we're doing well, what we're not doing well, and using it to improve care. So these components, I think if you reflect on it a little bit, will make you realize that we do have pieces of a learning healthcare system anywhere in any hospital, any clinic that we're working in, and that we as leaders have this opportunity to pull this together holistically so that we have a system that is perpetual. I borrowed this slide from my colleague and friend Claudia, who's got a deep understanding of learning healthcare systems, and it's really cyclical what we're talking about. We're talking about and with the patient in the middle of it, so that we are really attentive to their needs and their families' needs, but always using the data, the performance, and the knowledge in a cycle, and always reflecting on that. And I think part of the learning healthcare system and the cycle or augments the cycle is engaging the patients, but other external stakeholders that might be in this space of patient care, but we don't always think of them as being part of the patient, of the immediate cycle of learning. I'll give you an example. Right now, we are engaged with working with sterile processing. Now, sterile processing often is not considered to be part of the learning cycle or part of the immediate care of the patient. But when you have an issue with an instrument, or you delay a case, or you don't have the right equipment to care for a patient to do a bone marrow biopsy, they become part of that cycle. And so thinking more broadly of the context that we're taking care of patients is really inherent to a learning healthcare system. There is no boundary to a learning healthcare system. All stakeholders are welcome. All stakeholders' knowledge and data is inherent to the performance for our patients. And so it's a really inclusive way of thinking about healthcare in a continuous improvement mentality. So what are our roles in the learning healthcare system? And I just want to break it down into 3 parts today, and I hope that will feed into how we sustain the gains of a learning healthcare system, because it really comes down to us being ready as leaders and providers, us being receptive to the change and to what is inherent to the continuous improvement of a learning healthcare system, and using the learning healthcare system to be responsive to the challenges that we're all part of every day. Some are small fires, some are big issues, but how do we use what we've learned or what we already have embedded in the learning healthcare system to be responsive to the changes that undoubtedly we're going to be faced with? So readiness. Readiness is really almost part of a cultural transformation that's needed to embrace a learning healthcare system. And I would again say and be very clear that I think the fact that we're talking about it, the fact that you're interested in this, the fact that we have more and more examples of learning healthcare systems means that we're being more and more ready for what's ahead of us. We had to, 10 years ago, well, almost actually 15 years ago, had to ready our organization that I was working in, because we at that time there was no real embracing of continuous improvement and continuous readiness. And so we had to ready the teams using formal training. When I reflect on it, the training that we put in place that we called crew resource management, we actually partnered with some pilots and an astronaut, and really brought them into the hospital and trained nurses, physicians, and administrators together in a session that was mandatory for them to be part of the team. Initially it was, and this is how things improve over time, initially the training was 4 hours, which you can imagine, asking a bedside nurse for 4 hours of their day, or asking a physician for 4 hours of their day, was quite enormous. We did it, but then over time we evolved that training to make it briefer, bite-sized, and embedded in all onboarding processes. But it spoke to how we had to initially come out of the gates relative to improving the readiness. And then over time, we were able to evolve even that infrastructure so that it became innate to everything that we did. And this training was really around sharing, a vision of what was going on with the patient, stopping the line, see it, say it, fix it when you saw a patient safety issue, and really being able to have crucial conversations without risk of to yourself or your team. We embedded it around a purpose of really sharing checklists. And these checklists, again, this was when Atul Gawande had just come out with their New England Journal of Medicine paper. So it was a really good time for us to use this as the why and the platform for readiness. But it evolved. And 15 years later, we're still evolving this program. Again, it's around using visual management and using ways in which we can engage teams, not only in the operating room, but also in the endoscopy suite and in the radiation oncology suite, so that we all had a shared understanding of what we were responsible for the patient. And these tools, as part of the readiness, have continued to expand even after leaders have come and gone, because they're innate to the culture of continuous improvement now, and they use it as a readiness tool. We did, and I think this is really inherent to an implementation science and to a learning healthcare system, continuously measure the cultural acceptance or the cultural readiness for change. We use a standardized survey, the AHRQ survey, and every time we put out more training or we engage people in a different way, in a different format, we measured with short, brief surveys to see where we were doing well and where we still needed to engage people differently or at a different tempo because they weren't ready or there was different things that need to be put in place. But that measurement strategy is inherent to the learning cycle, and feeding it back very transparently to those that were part of it engenders that trust, but also that acceptance that they're part of the cycle of improvement. And then lastly, for readiness, we had to train enough like-minded and open-minded team members in improvement tools. And now fast forward, there's such great education, there's great frameworks for quality improvement and continuous improvement. And so we just formalized this in some fun workshops, getting people together that had never been connected. Here we have Eric and Ryan, one's an ENT surgeon, one's a psychiatrist. I mean, they're working on a simulation in the emergency department. Well, these were groups that would never normally have come together, and yet we were able to do it around professional development, having a bit of fun, but also adding to their education in how to improve the processes that they were involved in. And so their patient changed a little bit and became stick people, but ultimately it got the message across that everybody can have a role in a learning healthcare system if given a few tools and opportunities. And so it really was sharing this readiness was around understanding how do we do things a little bit differently. And, I think we as leaders in healthcare see a problem, want to fix it, see a problem, put a solution in place. But rather in the learning healthcare system, often there's small tests of change, and there is no quick fix in many instances. There is no finish line, because we're always trying to do better. And focusing on the process, whatever the process is, will ultimately improve the outcome. But this type of mindset of always thinking differently, how can we make it even better? Always thinking about what is our definition of a good and what does it mean for the patient, is part of the readiness of a learning healthcare system. And I think all of us as healthcare providers have this innate ability to think differently. And sometimes we just need to have a few extra tools, infrastructure, and a shared vision of going forward. And this is just a group of our team members that we trained in quality improvement. We partnered with the business school, again, a format that you have here in Ottawa, so that, our gastroenterologists, our hospitalists, our nurses, some of our administrators could go through this cohort of training together. And then when we had a process improvement initiative, we had teams that were ready for it, but also understood the tools used in these processes. And this type of programming continues today because it adds value to their own professional development as well. So what we've found in the learning healthcare system, or what I have kind of perceived, is once you get ready, then you have team members that are open-minded to continuously improving, using the data and the resources that you're already using to make the outcomes even better, and then being receptive to the feedback that comes from this cycle of learning. And I think being receptive and open-minded is, again, innate to how we are in healthcare, I think, in many instances, and sometimes it needs to be formalized. So again, many years ago, and I'm dating myself in some of these papers, this is a paper I wrote in 2012 when we were starting to roll out robotic surgery at our institution. And when that rollout was occurring, we were thinking, how do we bring teams together so that we learn from the surgeons that are doing it this way and the surgeons that are doing it that way? And we did it under the auspice of quality. And so we had very high level programming. We brought team members from all disciplines together to develop these scorecards. And then over time, the scorecards served as kind of a nidus of excellence. So there was comparison, there was sharing, and it was the beginning of understanding that through data, we can improve outcomes, and it's not scary. It can be collaborative. We can be at the same table, and it's okay if we have different types of patients or we expect different outcomes, but we collectively are sharing the vision that we want to improve as we go. And fast forward, this programming, this infrastructure is now enabling us to now, bring on more types of disciplines into this domain. But it served as a foundation for us to learn from everything we were doing. And then fast forwarding, it allowed us at the programmatic level to allow us to develop more balanced reporting. So I think, we measure data here, we measure an outcome here, but really being able to use a mentality around learning healthcare systems to put together what's I refer to, and many refer to, and you have, a balanced scorecard. So if you have the patient in the middle of the scorecard, how do these metrics of success influence those outcomes? And it may be readmissions, it may be patient satisfaction, it may be length of stay. There's many metrics, but if we decide upon them collectively, measure them, and continuously improve on them, then we're able to develop this value-based healthcare. And through time, we were actually able to move from kind of the process metrics to outcome metrics, and from quality to value. But it takes time, and it didn't happen overnight. And it took a lot of conversations to translate these pieces of data, this scorecard, into a value equation that we were able to pull together based on quality and cost. And this is really the definition of value-based healthcare. Again, it's a journey to get to this point, but ultimately we're looking at the value for the patient and in the eye of the patient and family that we're delivering through these metrics, through this opportunity scorecard. And all of this to say that I think it's important in a learning healthcare system to realize that we, sitting at the table, can define how we are not only measured, but perceived. Because there are many, many entities out there, including some in Canada and other countries, that are going to have their opinion as to how we provide healthcare. And so we have this ability, understanding the pieces of a learning cycle, understanding the pieces of a learning healthcare system, to be at the table and to define how we want to be measured. Because our clinically validated outcomes, our patient satisfaction matters. And if that's how we want to be measured, then those that want to measure us will listen, because we're at the table and we are the best content experts, because we are the ones taking care of the patients. And so this is becoming, a cottage industry about ranking healthcare. And the more we, with our national specialty societies and our own entities, our own healthcare systems, are at the table, the more we'll be informing what the measurement strategy looks like. So it shouldn't be, shame and blame for public reporting, but ultimately we should be able to use this data in a cycle of improvement between our peers, between our colleagues, and between our institutions, so that, this is again a paper I wrote some time ago that really speaks to the paradigm shift needs to be, how do we collectively improve going forward rather than piece at a time. So we've talked a little bit about being ready. We've talked a little bit about being receptive. And I think that as we work within healthcare systems, being ready every day for the challenges is entirely innate to what we have to face going forward. And when we're trying to be ready every day in a learning healthcare system, it's identifying that there is, and being brave enough to say that there may be a problem that we can improve on, and that transparency and that reality is needed. There's also this constant need to engage stakeholders. Now, this could take time. The patient, the providers, the system, bringing together the stakeholders and taking the time it's going to take to get to a consensus for improvement is so necessary, well served time, but also in the end will make the next problem or the next solution even easier to come to, because you've already got the engagement from the previous issue. And then lastly, always measuring. And this, again, needn't be complicated, but measuring and sharing those outcomes and that measurement strategy with everybody involved really makes us ready for the challenges ahead. And then lastly, how do we use the readiness and the receptivity to be responsive? And being responsive in a learning healthcare system allows us to improve. And those improvements can accelerate as we're more and more responsive to the challenges that we have. This is not responsiveness, and it's what we need to get away from when we have these challenges. And that's kind of the first response. Oh my goodness, something's going on. We have to change. It's not going to make us go forward, but rather using all the tools we have, all the excellence that we have, the people, the open mindset to really be responsive. An example we had that I was able to be part of and was so lucky to be part of was in Central Sterile Supply, where we clean all of our instruments, all of our scopes, all of our kits come out of. And we had this ongoing issue of just not having the tools at the right time for the right patient. And so really engaging with the teams, we were ready, we had an open mindset, we were receptive to the good and the bad, allowed us to engage with the teams that had, in many instances, we had never had providers meet with those that were doing the work. And that concept of bringing teams together was really very rewarding. And it resulted in not only better outcomes, but ultimately a vision to improve the entire way that we took care of our instruments and prepared all of our sets for the entire hospital. And we were able to set up a new way of doing this with the teams doing the work and engaging across all the different stakeholders. Similarly, we had an opportunity within the hospital whereby there was a sense that every patient had to be monitored to be safe. So they had to have telemetry, they had to have oximetry. So every patient was awaiting, especially if they were in the emergency department, moving them from the emergency department to the floor, there was a backlog because telemetry, there was only so many units and so many floors that could monitor to that degree. So we took it back to the root cause and understood with the nurses and the patients and the providers what it was that was driving this, and collectively able to look at, who needs to be monitored, how do we leverage our IT systems to make it easy to order the right admission order set so that the right monitoring was put in place, and then how do you enable the teams to take the monitors off when clinically appropriate. And here you can see Todd and Tom, who are working on with the nurses, the alarm systems, that how do you make the sound such that the nurses know which sounds to respond to in which way. And this became an ongoing work that we did in the system for many, many years and continues now as we always improve how we're monitoring our patients. And in fact, resulted in fewer patients being monitored with all of the telemetry and oximetry, and improved outcomes for the patients and their stay in the hospital. This is just another example. We had this great opportunity to build a new hospital, and you can see that here's this big hole in the ground. And what we were able to do, and we hadn't done previously, was really think about it through the patient's eye. So we were able to be responsive to the needs of the patients by engaging them in a very new opportunity. And what we did was, worked with our patients and our advisors to think about, if you're the patient and you have a blank slate, what does it look like for you to be cared for in this hospital? We had to do a little bit of virtual reality because obviously the building wasn't built yet. We brought the nurses and the physicians and the patients together into these mock-ups. We did a lot of paper and cardboard and styrofoam. And quite interestingly, we kind of drafted out what we thought, we as administrators and some of us other leaders, what we thought would be the right patient room. And the patients were picking up the cardboard toilets, and they were picking up the monitors and saying, no, this isn't where I would want it to be. I would want it to be here, not here. And so it kind of took us back. So we had to be responsive to their feedback, took it back to literally the drawing board and reconfigured what the layout would look like in the patient and the family's eyes. Very humbling, but I think ultimately will serve us well as we go forward with new patient environments. And then lastly, being responsive to when things don't go as we had planned. You know, the best plans, the best processes always can be improved on. And when you're able to get, you can celebrate the successes as we have done in other institutions, but when the things don't go well, when you're responsive in a learning healthcare system, I think we have that innate humility to work with our patients. And this is one of my favorite patients, Nina, who helped me understand fall prevention and what it meant to prevent falls everywhere in the healthcare system, from the emergency room to the outpatient, because it was through her eyes and her husband's eyes, who had fallen in the hospital, that we're able to engage with and be responsive to their feedback. And so taking that time, taking that open mindset with the patient in mind, just enabled us to do things so much better and very differently. So pulling it all together, and I've talked about this cycle, you know, this learning cycle in a learning healthcare system, I think it's actually more like putting the pieces of the puzzle together in order for us to work cohesively and leverage a learning healthcare system. And in particular, I think, you know, you need the quality infrastructure, you need the operational infrastructure, you need the research, because you need to learn from everything you do, and then that education so that we train not only ourselves through professional development, but our learners and our medical students and our nursing students and all of our health professions in this ever-changing puzzle, but that ultimately can be pulled together to improve the system that we work in. I'll just give you a few examples of how how gains can sometimes be sustained through the lens of research, through the lens of operations, through the lens of quality and continuous education. And really this concept of building small, getting things to work well locally, with a global picture of making the overall experience good. So if you can fix and improve the way that we take care of patients, maybe in your reception area, and how patients come into a day procedure, how do you amplify that then across other intake parts so that you can improve the overall experience? If you can improve the way that we discharge patients from the emergency department, how do you then translate that to how we discharge patients from all areas in the hospital? So starting small with the model cell and then moving and thinking more globally will allow us to be continuously moving in the right direction. Similarly, integrating the research and the ability to disseminate the best practices as well as challenges was very much inherent to what we did. You know, we had to get it right first. We had to develop our processes and some of our infrastructure, and then we started engaging residents and medical students and researchers in what we were doing, so that we were disseminating the information. We were getting grants because they wanted to study how we were doing this. And the more that we kind of made them integral, at some point, we didn't know the difference between, you know, a provider and a researcher. They were working hand to hand with the patient on improving their experience using the electronic medical record, because we were all part of the learning healthcare system. And then lastly, and this is a slide from a paper from 2017, Bill Smoyer, who is a professor of pediatrics at Nationwide at OSU. He always had this concept, and it took him a long time to get this concept across to people, was that we can learn from every patient. That every time we have a encounter with a patient, every time we have a conversation with a patient, every time we measure an outcome of a patient, we can put that back into the cycle. And he coined this phrase that I think will resonate with all of us, is that we can learn from every patient to improve outcomes. And I am very grateful to Bill because he was persistent in understanding how to do this more globally outside of his specialty. And it really did resonate with many of us that we have this ability, we have this innate data, research, evidence-based practice, all in this continuous improvement cycle that we can thank the patient for and really engage the patient in, so that we learn from them every time. And so with that, maybe I'll just end and open it up to questions. And I hope that the readiness, the receptivity, the responsiveness, and then just embedding and learning from every patient resonates with you. And I'm truly, again, indebted to being here today. It's been a pleasure.
Well, thank you, Susan, for a truly inspiring presentation. And we have many people on the line today, so please raise your hand if you have a question, and I can reach out to you. So Dr. Bromwich.
Matt, just unmute there.
There we go. I thought I did, but my finger obviously did not hit the button. I had the good fortune of listening to your talk twice, because I attended it as a surgeon, and then I attended it as a member of the pediatric department as well. And I'm also the lead of our innovation group here at CHEO. And it struck me that many, like, what is the difference between innovation and what you're talking about? And to me, really, it means collaborating with outside partners when we don't necessarily have the tools to solve the problem internally. And I was really curious about what your experience has been with that when you're trying, like your first slide about being most responsive to change. If we don't have the tools inside the hospital, to me, innovation means partnering with basically companies or people outside to bring technology to life, so we can then bring it into the hospital and implement it. How does that fit in with what you've been talking about?
So Matt, that's a great question. There's two examples that I can probably bring to bear on this one. The first one was partnering. So as part of a university, early on relative to the readiness, we partnered with the business school to help engage and train our teams in some of these tools that we hadn't traditionally had within our curriculum. And then that actually allowed them to come into the hospital as well and partner with us on some of the improvements. And in fact, one of our MBA class studied transplant outcomes using a tool to help discharge patients. Transplant patients go home with these long lists of medications. And so our operations people from the business school could partner with our nurses and our faculty to improve the process. So business school and the medical school came together. The second example I might give you is that we were fortunate to be very close, physically to Battelle. And Battelle are obviously, a powerhouse relative to data and informatics. And they helped us understand how to collect data safely and then to use predictive modeling to look at kidney failure in the ICU. So, when they first started the concept, they had no idea what a creatinine was or what, a kidney function was. And we had no idea what they meant by a data mart or a data lake at that time. This was, 10 years ago, but we were able to come together. Took time, those relationships take time, but I tell you, ultimately, and then with the next challenge, when we went to look at COVID vaccinations, Battelle was there. And so we had already had the success that then lended to the next conversation.
Amazing. Quick follow-up there. Was that primarily funded through academic interests? Like when you linked with the business school, was that through professors and their students essentially?
Yeah, well, basically it was almost like in kind, right? So the students, the MBA students needed the experience and we needed their help. So it was a resource that was shared.
Amazing, thank you.
Susan, I have a question, a two-part question. Much of what we read about learning health systems, a lot of the literature comes from the US, and given your unique perspective being in the US and coming back to Canada, I wonder if you could speak a bit on some of the differences between the two systems and perhaps how we can leverage some of the opportunities that are unique in the Canadian system to implement learning health systems. And then as a second part to that question, how do we incorporate that in the teaching of our trainees? You alluded to trainees in your talk, so that the next generation, this is inherent in what they do.
Yeah, no, those are great questions, Jason. So I think first and foremost, I think we can learn from what the US system is already kind of leveraged in developing learning healthcare systems. So we can see the lessons learned as well as some things that we would want to improve on. I do think that in Canada, we have an opportunity. The fact that we have interest, we have people, we have a finite resources. We also have a finite number of patients. And I think that we actually have a healthcare system that we can get our arms around. There's, 6,300 hospitals in the US. And so I think in Canada, we have that ability to get our arms around the healthcare systems that we work within to leverage a learning healthcare system. And just from what I've seen in the very short while that I've been back in Canada, we have a lot of the pieces. And you have great leaders that want to pull it together now around the patient. So I think we have a great opportunity here, Jason. And I think that, the future is very, very bright relative to the learning healthcare system. I also think that relative to teaching our medical students and residents, these are new skills: data analysis, continuous improvement, systems convener. These concepts need to be and are being integrated into the medical school curriculum and into the residency curriculums. I think it's a great opportunity, and we as the leaders and maybe the more senior faculty need to be also armed with that knowledge so that we can train our residents and our medical students and all other type of students that we see in the healthcare system. It's a common language, right, around continuous improvement.
Thank you. Other questions?
Thank you, Ivan.
Good morning. You had a great slide where it called out the clinical and research data collection integrated into provision of care. I'm wondering if you can expand on how you balance the data, discrete data collection piece with the actual patient care, because obviously we want to collect as much excellent detailed data on the patient as possible, but there will be a bit of pushback from the end users that are inputting the data and providing the patient care, as well as from the patient perspective itself. So how do you balance that?
Yeah, so it's really trying to make it as easy and as structured as possible. So for instance, relative to the input, the more that we can use, barcodes on medications, on instruments, et cetera, makes it easier for us to record the data. Templates that allow us to collect the variables that go into the predictive modeling relative to outcomes, making it such that our order sets and our clinical pathways are really integrated and leveraged through the EMR, whether it's Epic, Cerner, et cetera, so that it's easy to do the right thing and the same thing over and over again. And then I think it's where the operations and the research and the quality come together in understanding how do you take that data from the different sources and output it in a meaningful way. And this takes several iterations, but we have so much data. How do you take 3, 4, maybe 5 metrics to start, pull it together and put it in a format that anybody can interpret so that they at least get an understanding of the process, where you're at, and how, if we're going up or down in our outcomes. We got to start small, have to be integrated. And I think that making it easy to get the right data in will help the output ultimately.
Thanks, Ivan, for that question. Dr. Malik.
Hi, Susan. Great presentation. We asked this question also at the surgical round because we are a department full of very rich of data. Do you think that in order to get that balance and to define the value in our system, do you think that our current EMR can give us everything, or do we need something else on top of the EMR or somewhere else, a hub to have?
Thanks, Claudia. And I think it kind of goes back to the previous question. I think you start with what you have. So start using, use or continuously use the EMR now. Pick 1, 2, or 3 metrics to mine that data. Make sure that it's inputted, make sure it's validated, and then it's output in a way that you can. And once people get comfortable with that data source and the validity of that data, then you can add on other sources of data, whether or not it's NSQIP or any other qualitative or quantitative data that you might want to add to that scorecard. But start small, start with what you already have, and make sure you validate it with those that are responsible for the data along the way.
Dr. Jabour.
Hi, thank you. Good morning, Susan, and thank you for that great presentation. I think a lot of the concepts and the how-tos that you talked about really resonate with so many of us. My question, I'm particularly interested in implementation science myself. I'm particularly interested in, how you make this happen on a, not necessarily every day, but on a more regular basis. So, you have the audience here is pretty committed to research and promotion of research. How do we make that shift from that collective mindset shift, both from the hospital perspective and the patient perspective, to really think about, currently there's clinical and then there's research. And if it's a research project, oh, this is a research project. How do we truly integrate that so every patient that comes to our doors understands that they are contributing to research, they're benefiting from research, they're experiencing the findings of research? Just wondering if you could speak more to making that mindset shift for us.
Thank you for that question. And I think, when I reflect on how we were able to enable that, it's something that almost didn't happen. So why I say that is that I think that in many institutions, you're right, research sits here and clinical sits here. And in my instance, I was trying, as a quality officer, I was trying to reduce central line infections. I went to the literature and I found one of our researchers writing about it. And yet I had no idea that they were an expert in, central line infections. And so, I pick up the phone and I said, hello, hi, Anne. You don't know me, but I've read your literature. Can we connect? She shows up. Of course, I'm too busy. And I said, no. And Anne sat in my chair until I was ready to talk to her. And from there, we had that collaboration. So Anne as the research, myself as the clinical quality lead, we developed a partnership. I then took on a graduate student to help me study the outcomes that I was implementing. And then it just kind of blossomed from there. And then though, like when Anne was writing, a grant for SMART, which was actually a whole grant that we had on reducing central line infections, she needed patient advisors. Well, I'm the clinical quality lead. I am working with patient advisors all the time. I connect the two. And so it just became kind of, but you need that connectivity, you need that relationship, and you need to take the time to pull it together. Having a graduate student and having some of the learners invested in doing clinical rounds with us, I mean, they immediately saw some of the opportunities to write about good and bad that then perpetuated their ability. And those relationships last a long time. The human factors team members that got to come into the hospital and be part of our everyday, intake process, man, they were so awesome. And now they continuously work with us. So they become embedded in the process, but you got to open the door and you have to develop those relationships.
Great, thank you.
I'm just looking if there's any other last questions. If not, I think that's a great place to end. Please join me in thanking Susan for taking time out of her extremely busy schedule to join us this morning. Thanks to all of you for joining us. I think this really was inspiring, and I see some notes in the chat about how this resonates with many of you, and so look forward to moving learning health systems forward at CHEO, and also we'll be moving forward with our next PSI series. We'll be applying for funds for PSI for our next lecture series. More information on that to come. So thanks everyone. Thanks again, Susan, and have a wonderful morning.